Hi, my name is Janet Gripshover, and I'm the nurse manager for Cedars-Sinai Liver Transplant Program, and I'm a board-certified nurse practitioner. So I'm so excited to talk to you guys today about some hot topics in cirrhosis. Now, cirrhosis is the top of the scale for how we measure damage in the liver, and it's generally thought of as an irreversible disease. However, in some cases, very early cirrhosis, so cirrhosis that's really only detected by imaging and without really any symptoms, may be reversible if the disease state is adequately treated. However, we don't really know at what point of no return there is, meaning at what point that there is absolutely no chance of fibrosis regression. Although we do know that once cirrhotic decompensations arise, then it's likely too late. And the only treatment at that point really that can cure cirrhosis and improve the quality and quantity of life for patients is a liver transplant. Transplant is still the only cure for end-stage liver disease produced by cirrhosis. However, there's also been some developments that increase the likelihood of getting a transplant or possibly even delaying the need. One of the things that I'd like to make sure that you guys know is that we are, generally speaking, across the nation transplanting earlier than we have before. Now, again, it's a wide range, but there's been a lot of developments out there in using more organs and getting more organs ready to be able to be transplanted in patients. We generally recommend that anybody who has any decompensation, regardless of MELD score, gets referred for a liver transplant. And once a decompensation arises, then the average life expectancy is less than 2 years. Alcohol is still the #1 cause of cirrhosis in transplant. There have been multiple initiatives to either incorporate or co-locate alcohol use disorder treatments in hepatology clinics. And early transplant for those with less than 6 months of sobriety is really a growing field. However, criteria for who would qualify for getting an early liver transplant really varies largely from center to center. Generally speaking, many centers will look at a patient's support systems, patient's prior knowledge of their alcohol-related liver disease or severity of alcohol use disorder, and prior attempted abstinence in determining whether a patient is ready or able to be a good candidate for liver transplant. The fastest growing disease state that's leading to liver transplant and cirrhosis is metabolic-associated steatotic liver disease, basically what was previously known as fatty liver disease not related to alcohol use disorder. To treat this adequately, the recommendations still say that we should encourage patients to achieve at least a 7% weight loss, as this can really improve the disease state. It mobilizes the fat out of the liver and can really reduce progression of cirrhosis into decompensated states. There's been some data out there as well that says that once somebody has developed cirrhosis, it's important to work with them to identify a surrogate decision maker to help them make decisions based off of their values. Again, from the first decompensation that a patient may get, average life expectancy is less than 2 years. And some of these decompensations that patients can get can render them unable or making it very difficult for them to make good healthcare decisions. So having a surrogate decision maker involved in the process along the way can help make good clinical decisions for the patients based off the patient's values. Thank you for listening, and for more information, please visit the GAP website or download the GAP ACE app available on iOS and Android devices.